I'm Jim Cameron. We sort of met earlier today. So one of the things that's quite controversial and a moving target at the moment is various interactions in management between oral anticoagulants and dual antiplatelet therapy, and it's probably becoming less of an issue with some recent papers that have come out. So I'm going to just share discussions about these papers and try and come to some conclusions, because as I said, it's a moving target. The guidelines are changing all the time, so I think it's something that it's probably worth just looking at what's emerging in the research and trying to make sense of it. So these are a couple of patients I just pulled out of my patient diary, which are pretty common scenarios these days, and these are the combination of patients with AF anticoagulants and having stents. So case one is someone with AF pacemaker, vascular risk, and a non-invasive test showed a severe lesion in a large diagonal. Patients on rivaroxaban for atrial fibrillation, other drugs as well. Post-stent, we chose to use a combination of rivaroxaban and Plavix or clopidogrel, and we'll go through and you can see why we've emerged down that pathway. Second case, also very sort of similar, 78 years female, AF6 sinus pacemaker, severe ostial right coronary lesion, treated with a drug-eluting stent, also on rivaroxaban, and post-stent rivaroxaban lower dose and clopidogrel. So we'll go through this and you'll see why we've come to that sort of therapeutic regimen from the current research. So some of the learning objectives today are when and how do we use these agents? I mean, we've now had NOACs for probably around 6 years, so we're getting used to those compared to warfarin. We've also now have to sort of work out how to use all of these agents when our patients are having different surgeries, colonoscopies, major surgery. We're trying to work out how we use them in those. We're also learning the risks when we use these drugs, oral anticoagulants and antiplatelet therapy concurrently. And then how do we move on to optimise the outcome and minimise the risks for patients, both in hospital and post-discharge. So this brief overview of the extent of this problem. Both atrial fibrillation and ischemic heart disease and stenting are really major issues, and the risks are actually high in combination. So the atrial fibrillation incidence globally is somewhere between about 0.5 to 1%. So that's obviously a guess, because we probably don't know, but it's a guess. We do know that the incidence climbs as you get older, and it's probably more than 10% over 80 years. More than 5% over 60 years, and a quarter of embolic strokes are associated with atrial fibrillation, and we know that they're often larger and have a worse prognosis. The incidence of atrial fibrillation is increasing worldwide as we're seeing epidemic with diabetes, obesity, sleep apnea, all of these things we know promote atrial fibrillation. But there is a 2/3 relative risk reduction of stroke on oral anticoagulants, so there's the huge benefit in treatment. This slide is from the Australian Institute of Health and Welfare, and it just shows you what's happening with hospital admissions in Australia between 1993 and 2007, and on the y-axis, 10,000, 20,000, 30,000 per year. The dark bar is atrial fibrillation, and you can actually see that there's an increasing rate of admissions over that whole period, and it doesn't look like it's abating. Interestingly, myocardial infarction also going up, but heart failure is steady. But interesting, so there's a big burden of atrial fibrillation in the community. What about ischemic heart disease? Also some statistics which are interesting. 4.2 million, or 22% of the population, more than 18 years of age has at least one CV disease. So that's a pretty amazing fact. So huge population problems. Just some statistics: stroke, 35,000 strokes in Australia in 2014. 50,000 cardiovascular deaths, and that was 34,000 of all deaths in the country in 2008. Coronary revascularisation procedures in 2015, 48,000 in Australia, of which 36,000 were stents, angioplasty, and about a third of them bypass graft surgery. So that gives you just an extent of the problem. So coronary stents and atrial fibrillation commonly occur together. The research I read said that 8% of patients having stents have atrial fibrillation. I think it's actually higher than that. I think it's an increasing problem. Atrial fibrillation and patients with mechanical valves both require ongoing oral anticoagulants. So it's very rare that we can actually stop oral anticoagulants in patients having stents, because generally they're required, and the evidence is that they need to be kept going. Stents, on the other hand, on their own, we use dual antiplatelet therapy, and we know that dual antiplatelet therapy is associated with much lower risk of stent thrombosis than single antiplatelet therapy. So that's why we use that. So then we have a dilemma. So where do we use in atrial fibrillation and oral anticoagulants? What are the issues? Where do we use them? So there's atrial fibrillation is, as you know, is generally divided into non-valvular and valvular. Now, valvular means mitral stenosis and mechanical valves, not just mitral valves. So it means mitral stenosis and mechanical valves. Both of those require warfarin if you've got a patient in atrial fibrillation. There's no evidence base for NOACs in those groups, and where it's been looked at, so far it hasn't worked. Non-valvular atrial fibrillation means every other type of disease in atrial fibrillation, including things like aortic stenosis or mitral regurgitation, are called non-valvular. So what we do with anticoagulants depends on the CHADS VAS score, and as we know, warfarin and NOACs have been trialled probably similar in terms of their efficacy in preventing thromboembolism. The current guidelines are CHAD VAS score of 0, nil therapy, CHAD VAS score of 1. We use aspirin or oral anticoagulants, although the European part is suggesting oral anticoagulants and not aspirin. 2 or more CHADS VAS, we definitely I think worldwide people recommend oral anticoagulants. So what about drug-eluting stents and bare metal stents? Drug-eluting stents, the current worldwide recommendation is for aspirin and a P2Y12 inhibitor, which is either clopidogrel or usually ticagrelor. So we usually use aspirin indefinitely, and we use a P2Y12 inhibitor for 12 months. Now we vary that, and there's some evidence now we can shorten that to 6 months in patients. Bare metal stents, we've always used aspirin, and we often use that for at least 3 months, but often patients stay on it. The other agents, clopidogrel and ticagrelor, we usually stop them after 1 month. So, and the difference being is that bare metal stents endothelialise much faster than drug-eluting stents, so that's why you can use a much shorter course of dual antiplatelet therapy, because the risk of stent thrombosis is low in patients with bare metal stents after about a month of dual antiplatelet therapy. This is just a new type of stent that's come into the mix, and I'm just going to mention this. This is a study that was published in New England Journal of Medicine 2016 called Leaders Free. But what this study was about was a new type of stent where the polymer, which all drug-coated stents have, there was no polymer on the stent, so the drug was directly on the metal and it eluted into the wall of the vessel within about a month, and then it became a bare metal stent. So this is a stent that's got a drug, like we use in a drug-coated stent, but within a month it theoretically turns into a bare metal stent. So this was a randomised trial in 2466 patients using a drug called Biolimus, and it was particularly picked because it transfers into the vessel wall quickly and then leaves you with a bare metal stent. So the aim of this study was to reduce the duration of dual antiplatelet therapy and the bleeding risk, and it was used. 34% of the patients were high risk. They had atrial fibrillation, and the point of this was that they used 1 month of dual antiplatelet therapy, so it's more like a bare metal stent. So this actually worked. This stent worked. The safety endpoint, death MI, stent thrombosis was better with the polymer 3 stent, and the efficacy endpoint, in other words, whether the patient reblocked or not, was lower in the polymer 3 stent, 5 versus 9%. So this is actually looks like a good study, and these stents are now available. So we're just starting to use these now. They've just become available. There was no difference in serious bleeding. So this is a stent that you could use hopefully with the same benefit as a drug-eluting stent, but with the characteristics more of a bare metal stent, so you could actually reduce the risk of dual antiplatelet therapy. And of course, we also still use bare metal stents because the evidence is that if you've got a large vessel, 3.5 millimetres or more, and you've got a focal lesion, there's not much difference between using a bare metal stent and a drug-eluting stent. So you can actually pick your patients as well, and pick your lesion as well, and triage your stents according to that. So I'm just going to mention a couple of things which will probably be mentioned through this. Radiofrequency, and this is a part of the moving target, radiofrequency ablation. We're now curing some patients with atrial fibrillation and able to take them off anticoagulants. So that's one area where things are moving forward. And there's also the new procedure, left atrial appendage occlusion, which has just come in on the MBS in the last few months. And this is for patients who have atrial fibrillation, have a risk, and can't use oral anticoagulants. So this actually might be something that might help this whole process, and may become part of the mix. So faced with a patient who we've got a high risk of bleeding, and we think about the patient beforehand when we're about to do a stent. So we think pre-procedure about their bleed risk. So you can actually calculate people's bleed risk generally according to different scoring systems, and I won't go into those. They're somewhat intuitive in a lot of ways, but I think it is helpful to think about what that patient's risk is. Things like elderly, low body weight, renal dysfunction, they're all things that you'd expect. We try and now use radial approach versus femoral. This has been particularly demonstrated in patients with acute coronary syndromes where the bleeding risk is high, using more anticoagulants. There's definitely a mortality and morbidity benefit with radial approach versus femoral. So a lot of us who, including me, who've been old femoral advocates for years, we're now doing a lot of cases radially, and I think there's definitely less bleeding with it. I think it's the right way to go. Proton pump inhibitors, if there's a GE bleed risk, you can also, if you're stuck with doing a femoral procedure, which occasionally are, we can use closure devices. We minimise the use of things like heparin, and we also have expert nurses in the ward looking after the patients afterwards. And as well as that, we talk to our patients a lot before they go home about how to manage bleeding risks, etc., and what we do and what they do in various situations. So I'm just going to talk about 3 trials because this is where the interaction with the drugs is being looked at. And I'd point out that this, like the silly walks, there are a lot of sort of crazy ideas floating around before we started getting evidence. One of the themes here is that bleeding is a major predictor of adverse outcomes, so bleeding is the enemy. First study is this one here called WOOST, which was done in Europe in 2013. And what this study did was it looked at 573 patients who needed to continue oral anticoagulants post-stenting. They included 65% drug-coated stents, atrial fibrillation, 70%, mechanical valve, and 10%. So this is before the NOACs were freely available. So one group had double therapy, warfarin and clopidogrel, and one group had triple therapy, which was aspirin, clopidogrel and warfarin. So this study was very useful in that it demonstrated straight away that there's a huge increase in bleeding on triple therapy, 44% versus 19%. The risk of intracranial hemorrhage, which was the worst thing, was 1.1%, which I think is high, but it was equal between the two groups. But there was a much higher risk of morbidity-type bleeding in the triple therapy group. And I think anecdotally, I don't believe this figure here because I think we've seen some intracerebral hemorrhages since early on when we had stents, when we actually did use triple therapy. So I think we pretty quickly learnt that that was not a good thing to do. The actual difference in ischemic complications was similar, except there was a slightly higher risk in the triple therapy group, and this probably relates to bleeding risk. And the main message from this study, which I think just got everybody moving on the issue, was that there's a high rate of bleed on the three agents. You can't avoid that, and I think that's what's driven the research since then. So there's two other studies we'll talk about. This one is called Pioneer AF-PCI, which was published in 2016, so still fairly recent. So all of these patients, as opposed to the WOOST study where some of them had mechanical valves, all of these patients had non-valvular atrial fibrillation, and there's a bigger study, 2,124 patients. So in this study, and just have a look at the doses here, they were randomised to rivaroxaban 15 milligrams plus a P2Y12 agent, usually clopidogrel, rivaroxaban 2.5 milligrams twice daily, which is really not a dose that we associate with any other therapeutic context, so I'm not really sure why they picked that, but there would have been a reason. And they used dual antiplatelet therapy for a month, 6 months and 12 months. And then there was a third group, warfarin dual antiplatelet therapy for 1, 6 and 12 months. And if you look at this dose of rivaroxaban, it's actually, you would actually say that's actually not a fair comparison with warfarin, which I don't think it is. So the primary endpoint of the study was bleeding. So group 1, which was just a fairly standard approach, rivaroxaban and clopidogrel was 16.8%. Group 2, which was, I remind you, was the lower dose rivaroxaban and antiplatelet therapy, 18%, which was similar but a little bit higher. But group 3 was the warfarin group with dual antiplatelet therapy, and predictably was higher, around 27%. And I would actually point out it was lower than the 44% in the WOOST study. So actually was seemed to be less, but it might have related to less duration of dual antiplatelet therapy. The CV event, the cardiovascular event rate and the stent thrombosis rates were all very similar. So the main difference in the study was the bleeding. So the main message with this is that bleeding is less on the NOACs with the one agent versus, we should be one agent versus two agents. So I think that's actually, just go back and just show you that regimen. So we're actually talking about these two levels better than the warfarin level. So the last study, which is just been published at the end of last year, which I think is really sort of cementing all of these ideas, was the use of dual antithrombotic therapy, dabigatran, in a study called Redual PCI, which was a study published last year. Once again, these were all patients with atrial fibrillation. There were 2,725 patients in the trial. And the groups that they chose were warfarin, P2Y12 and aspirin. And they used dabigatran 110 milligrams twice a day, which is of course the low dose, plus a P2Y12, but no aspirin, and dabigatran 150 milligrams twice daily, plus P2Y12, no aspirin. Once again, they're sort of persisting in using warfarin triple therapy as a control, which is now, looking at those previous trials is a little bit unfair. Now, the primary endpoint of bleeding, once again in this trial, the 110 milligram versus of dabigatran twice a day versus warfarin was 15% versus 26%, and the 150 milligram of dabigatran twice a day versus warfarin 20% versus 25%. And once again, this 26 and 25% compared to the 44% in Woost. But it does actually, I think one of the messages coming across here is that we're talking about a NOAC and an antiplatelet in dual therapy, not triple therapy. So I think that's the message that's come out of these three studies. Just on the same study, the composite endpoints in ischemic and stent thrombosis was similar. So the main message was low dose NOAC plus a P2Y12 is less bleeding. The advantage also compared to warfarin, of course, is it's much easier to use. And of course, we also have a reversible agent for dabigatran now. So just sort of summarising all of this, what's the take-home message from where we're going with this, and what are we actually doing in current practice? So if you've got mechanical valve and a stent, or that could also be mitral stenosis, and you need to be on warfarin, then what we would do now is just use warfarin and a P2Y12 agent. Sometimes, if you thought the patient was high risk, you might use a low-dose aspirin for a short period, like a month. And I think some of us are still doing that, but the evidence does in fact favour just doing this. And for atrial fibrillation, we're now mostly where you can use a NOAC, we're using a NOAC in lower dose, not higher dose, and a P2Y12 agent. And I've got down here, consider a short course of triple therapy if high risk. So this will probably start to appear in guidelines after those papers have come out, and I think we've now got some firm way of taking this forward, and I think we're now not so fearful of being referred the patient with atrial fibrillation and a stent and worrying what's going to happen to them, not in the lab but after the lab. So I'm just put this here, I hope you're not too confused. So he's asking how's the squid? So, and any questions? So, because I think there's other questions that might come up that aren't definitely associated with this at all. So there's other things like operations and ischemic heart disease. So it's as I said, it's a moving target because all of these drugs are relatively new. So any questions at all?
Jim, I've noticed a lot of people coming back to me after stents years ago, like maybe 10 years ago, who then developed atrial fibrillation, and they're swapped from their antiplatelet therapy to a NOAC.
Mm-hmm.
And of course, this does really concern me because of the traditional must be on antiplatelet therapy. And I've now seen a couple of patients subsequently present with acute ischemic events. Was there any data on
No,
that?
there's not a lot on that at the moment, because I think an obvious trial might be, ischemic heart disease, NOAC and antiplatelet therapy for that indication, not just stenting. There's been one trial I'm aware of with using a low dose NOAC with or without aspirin or on its own in patients with ischemic heart disease, or with ischemic presentations, and the low dose NOAC and aspirin was better than aspirin or the NOAC on their own, but the bleeding risk was higher. So I'm not sure if that's going to translate into a clinical therapeutic approach. So I think I think it's too early to tell. I think that we probably need more trials on that, and I think it'll be interesting where that goes with that. But I think as I said, the theme here is bleeding as a problem. You might say, why is bleeding a problem? Well, someone comes in with bleeding and they're on antiplatelet drugs, which we think are otherwise essential. The thing then is that you might have to consider stopping them and then put the patient at risk of an ischemic event then. So it's a bit of a two-edged sword, and I think that what we try and do in that situation is not stop them and fix the bleeding, but it is an issue, I think. No? Okay.